So drug-drug interactions, this really becomes a really prominent issue, particularly with the protease inhibitor, Nirmatrelvir, ritonavir combination. Ritonavir, as we know, is a very strong CYP3A4 inhibitor. Many of us have had experience with ritonavir in the setting of antiretroviral therapy for HIV. It can result in numerous drug-drug interactions, and particularly so with patients undergoing chemotherapeutic therapy. And so it becomes very important to look for drug interactions for our immunocompromised patients for whom you might be considering this medication. However, it can be used with other ritonavir or cobicistas boosting regimens. So other antiretrovirals that also use CYP3A4 inhibitors, ritonavir and cobicistat, it's not a contraindication for the use of Nirmatrelvir. So the options in terms of how to deal with drug-drug interactions, you really need to look them up because the recommendations are different based on the drug and for different reasons. So in some situations, you do have to withhold the drug or adjust, or alternatively adjust the dosage of the drug. Consider using other COVID-19 treatments. This is particularly true if you have a CYP3A4 inducer, because then the activity of Nirmatrelvir is greatly reduced, and in those situations, it's contraindicated or not recommended to use Nirmatrelvir. And in addition, regardless of what you end up doing with the con meds, it becomes really important to also monitor for side effects, because though we have predictable PK, there's always a range in how quickly a patient can metabolize drugs. So the algorithm is to ask whether a patient is taking any other medications, including over-the-counter medications and herbal supplements, because there are interactions with some non-prescribed medications and Nirmatrelvir. Do these medications have potential interactions? And then in the case of significant interactions, again, decide whether the drug needs to be discontinued, dose adjusted, or an alternative therapy needs to be used. And if none of these are possible, is to avoid co-administration with the con meds completely. When you do end up dosing with a drug that can be used with Nirmatrelvir, that withholding or adjusting dosage needs to be done during the entire duration that you're treating with Nirmatrelvir, and then an additional 2 to 3 days after the last dose of the drug. That being said, that needs to be kept in mind if you have individuals in whom that you think there may be protracted or decreased metabolism of the drug. In patients with, that are older, for example, you might want to withhold restarting the con med for longer than 2 to 3 days, and this is a situation that you would consult with your friendly neighborhood pharmacist to make sure that that's done. So these are just selected medications that have drug-drug interactions. Those that you want to prescribe an alternative antiviral include phenobarbital, rifampin, voclosporin, clopidogrel, sildenafil, tacrolimus, St. John's wort. Some of those that you might want to temporarily withhold. I don't think I need to go through all of these, but certainly some of the chemotherapeutic agents where you want to stop the drug, that includes docetaxel, and then other drugs where you want to adjust the dose of the drug. But I do strongly recommend using the Liverpool COVID-19 drug-drug interactions website. It's a site where you can put in the antiviral that you're considering using, as well as all of the medications that your patient might be on, and gives you very clear guidance in terms of whether to dose adjust or avoid the two drugs altogether. The NIH guidelines also gives a list of medications that are contraindicated, and also a list of medications that are safe to use, which is always reassuring. So I do like to double check with the NIH guidelines as well. just before going on to that, one consideration is extended dosing of Nirmatrelvir, so that these guidelines on the NIH only refer to a 5-day dosing of Nirmatrelvir. In some situations, you may end up extending that dose to 10 days. And in those situations, there's actually a difference in terms of drug-drug interactions because not only is CYP3A4 inhibition occur, but there's also CYP2C9, and with longer dosing, the inhibition of CYP2C9 may create additional drug-drug interactions. So when you go on to the Liverpool drug-drug interaction tracker, you can actually select short course or treatment, which is important to do because you will see a difference.
So now we have Elizabeth, a 69-year-old woman who's had bilateral mastectomies for stage 2 breast cancer, followed by radiotherapy, is currently on chemotherapy with docetaxel and cyclophosphamide, and comes up with a positive SARS-CoV-2 test 2 days ago with slight worsening of symptoms over the last 2 days. So she's also coming in with symptomatic mild SARS-CoV-2 infection. And the questions that we have to ask is, one, is she at risk to justify treatment? And if so, what treatment might we give? Brinda, you want to take the first shot?
Sure. So I would go to the Liverpool DDI tracker. But I do think that for cyclophosphamide, that there is a use with caution sort of situation, but it can be used without dose adjustment for a 5-day course. For docetaxel, there is a recommendation to use another agent, meaning not Nirmatrelvir, because of the interaction. Though there's a little bit of discrepancy between sites on that, because I have seen that. So I think in this patient, I think I would probably depending. I mean, this is a discussion with the patient as well, because again, there's an oral agent for someone with mild symptoms as an outpatient, and an IV remdesivir therapy. But I think my preference might be remdesivir in this situation.
If you can get it, right?
If you can get it,
it definitely makes life a lot easier. Yeah. And I agree. I had to look this up as well in the Liverpool, and the language they use for docetaxel, they're very specific. They provide you some guidance. Yeah. Yes, it's a problem. Probably increases the levels by about 50%, that you can consider reducing the dose or perhaps discontinuing temporarily. But again, a decision you would make both in collaboration between your Liverpool website and your local oncologist, probably.
That's right, that's right. One thing I did check in the website was the 5-day versus 10-day. And there, the cyclophosphamide was a do not use. So,
interesting.
I mean, not that we ever plan to use 10 days in any of our patients, but it was interesting to me because that's not an uncommon drug that we see in our patients, that because the CYP2C9 kicks in after 5 days, that it has a bigger impact. So more of a reason to sort of push towards remdesivir if you could.